Good morning, everyone. Thank you for joining us for this Fireside chat. Very, very excited to be here. Today, we're going to be discussing a recent publication by the Tony Blair Institute, a leading global think tank, that described the need for preparing the NHS for the AI era, which is underpinned by a digital health record for every citizen. Now, as you know, currently, healthcare data sits in disparate silos, it is often not connected, and the paper describes the potential for bringing data together to not only improve the delivery of clinical services, but also to unlock the opportunities for prevention, as well as drive economic growth. And to discuss this further, we're very excited to be joined by one of the authors of that paper, Dr. Charlotte Refsum, who is Head of Health Policy at the Tony Blair Institute. Thank you, Charlotte, for joining us.
Thanks, Videha.
So, Charlotte, we've had an opportunity to hang out before, even though it wasn't in such comfortable environments. But I'd love to start by asking a little bit more about you, because I think your background and your experience plays a big role in why your team wrote the paper. And I think it'd be great to hear a little bit more about your journey to start with.
Yeah, perfect. Well, good morning, everybody. I'm Charlotte Refsum. I started out as a GP, actually, oh, thank you so much. I started out as a GP, and I left GP in 2018. I did a fellowship at the Faculty of Medical Leadership and Management, and I spent an amazing year where I was working with Bruce Keogh at NHS England and with Sarah Wollaston when she was chair of the Health Select Committee. And I have to say, it totally changed my sort of perspective on healthcare and seeing things from that sort of perspective and being part of policy making, but then also part of the scrutiny of policy making. So it was that was fascinating. And then after that, I took a role with KPMG to work in their global health team, and I travelled to 25 different countries and saw health systems all over the world. And that has informed a lot of the work that we've been doing on this digital health record, is sort of taking inspiration from different countries. And then this job at the Tony Blair Institute came up, and I thought all my Christmases had come at once. It was an election year, and it was TBI, and yeah, it's pretty cool. TBI is an interesting organisation. Not many people know, or people don't seem to know that much about it, but we work in 43 different countries, and those countries span a lot of countries in the African continent, Southeast Asia, the Middle East, Eastern Europe, the Caribbean, so lots of places. And so yeah, we have free rein in the policy and politics team where I am to write about the UK, about global, about health, about life sciences. So it's pretty exciting time. Thank you.
Fantastic, and it sounds like a great job, and I'm very jealous in many ways. I want to start by, we're both clinicians.
Yep.
And yesterday, I think very, very excellently, we started the day by hearing from a patient and a patient's perspective, which I think was really important, a really absolutely the right place to start. But I'd love to hear from you from a clinician's perspective and from a perspective of a healthcare professional. Why is a digital health record important? Why is it important to think about connecting data across different places? What does that mean for people that are actually working to deliver care?
Yeah, so I think, a lot of people here will be well versed in that, won't they? Because the idea of a digital health record has been around for quite a long time, and just intuitively it just completely makes sense. Why wouldn't you have all of your health information in one place? The safety implications of having all your stuff in one place is really important. Being able to deliver care across different institutions and have all that information to hand. If I went into labour in a different part of the country and I had a terrible blood dyscrasia, people would be able to know. So those sorts of things are sort of self-evident. I think the things that are changing, one of the things I find interesting about a digital health record, and a lot of people don't make the connection, I'm sure people here do, but a lot of people don't make the connection between the digital health record and the way it allows you to have different models of care. And I think it's really interesting, like new models of care, because if you want to have integrated neighbourhood teams, for example, and I think we do, I think they're a great idea, then they may or may not need to operate under one roof, but they certainly need to operate on one record. If you've got people with a GP coming in, a district nurse coming in, social workers, and all that, they need to be able to access the same record to have to deliver safe care and to deliver that new model of care. So yes, I think it allows us to deliver a completely different model.
Yeah. And I really like what you said there about how maybe people in the room might appreciate that, but that's not something that's common knowledge. So just picking up on what you said, how do you think we as a community can potentially explain some of these points better to those? And I suppose that's a big part of your role as someone who works in policy and is obviously close to government or close to healthcare leadership. How can we explain this better, or how can we make this case better? Or are we making it well enough? I'm not sure.
I think that we really do need to make that point more about the digital health record being a vehicle to change the model of care, to change the operating model of the NHS, because everybody has been talking for a long time about these, well, not a long time, actually since the election, about the 3 shifts, right? So Wes Streeting is, and he's absolutely right about the 3 shifts that we need to make towards prevention, towards community, and towards digital. And that's why we structured the paper under those headings. And we said, actually, the digital health record does all of those, does those 3 things. And we sort of specifically zeroed in on why it was really important to do. And I've had sort of genuine experience of talking to people who are working in the field of designing the data architecture of a digital health record. And I was talking to them and I was saying, and of course, one of the really exciting things is a digital health record, you can imagine different models of care, couldn't you? You know, you could do, and I was like, oh, really? You know, so it's the first time I'd seen it in real time, that somebody designing something, a techie thing over here, and clinicians over here, and not really meeting. And I think that, look, I'm not a technical person either, and the paper wasn't even really very technical. It was more of a political paper, sort of saying, like, we've looked around the world, everybody seems to be doing this, we should be doing this. But I think it's really important that people bring to understand, because the aspects of the clinical or the functionality of it is determined by the structure of the digital health records. So all of those technical decisions you make have an impact on whether you're able to deliver a new model of care, or whether it's really going to have the impact that you think it's going to have. So it's so important that clinicians and you know, techies work together to design the data architecture, because it impacts the functionality of it. So that's the point I would try and make. I don't think that has clicked in a lot of people's heads. I think there's still, everybody intrinsically understands the safety argument and the kind of, oh, I should be able to see my record. But what about being able to hold your record and then share your record with trusted third parties to enable you to manage your own long-term conditions better, to access digital pathways of care, which we haven't been able to do before, because you suddenly have a digital ID and all of your information is there. You can access remote care. You know, you could you can have outpatient appointments remotely with people, with consultants in different countries. It allows you to have totally different models of care. So, so that, I think, would be my advice, is making it clinically relevant.
Yeah, I love that, and I love what you said about bringing the different communities together, and I think that's certainly something that this community tries to do very heavily. So, thinking a little bit more, not too technical, but a little bit technical, in the paper you describe such a record as a data core that sits in the center, and then there are different users or access points to that data for perhaps providers and healthcare professionals, the patient themselves, or indeed payers or insurers. Can you tell us a little bit more around the thinking of that and how you came up with that concept?
Yeah, it's a simplified concept, I accept that, but you sort of, I said it was a political paper, and we had to sort of write it for somebody to read who didn't really have any prior knowledge, maybe of medicine, or even, it had to be read by a politician who would get it. And quite often, even when you speak to people who are quite senior in healthcare management, they don't get the tech, right? I don't blame you, but so you can be certain if they don't get the tech, then the politicians don't get the tech. So to a certain extent, you have to kind of simplify the model. So what we were saying is that there are digital health records around the world. They vary in shape and size. They have different designs, but they have some core features, right? So they tend to have a data core, which is usually cloud-based, and it can be centralized or federated. It may have all of your information may be stored in a bubble in the cloud somewhere, or it may just collect that information as and when required from a federated system. Fine. But you have this data core where the data sits, the linked data sits, and then around it you have the analytics layer. And then we talked about 3 lenses into that digital health record, or 3 platforms actually. So we talked about the patient, the provider, and the insurer. So for patients, that patient portal is it's a really important sort of perspective on it, because through, I mean, you can imagine in the UK that would be like the NHS app. And the NHS app at the moment has fairly limited functionality, but you could imagine it having a huge functionality.
Yeah.
If you look at patient portals for big healthcare companies like the Apollo's Hospital Group in India, or you can access so much through their patient portal. As you've logged in with your digital ID, and then that you're able to navigate, access sort of white-labelled apps to self-manage your condition. You're able to do remote appointments. You're able to book blood tests and do all sorts of things. So that was the sort of patient portal. And then you've got the provider portal, which is, enables. And we sort of talked about the value of a digital health record. And this is the other thing. I think the value of a digital health record is much more in primary and out-of-hospital care than it is in hospital, because when you're in hospital, you've got electronic health records, and it's usually episodic. You're in, you're out, you get a discharge summary at the end. There's no real need for the digital health record to have every single blood pressure measurement you had in hospital. You just need to know what operation did you have, or what were you admitted for, what allergies did you, what medications did you come out with. So we had the provider lens, and then we had the insurer lens, and I knew that would get people twitched. But the thing is, in other parts of the world, that they have an insurer, and actually in the UK we have an insurer. We just don't call it an insurer. We have the NHS, and I think it's really important that the NHS, as a sort of payer status, has an understanding of the risk profile of its population. So it can all be anonymised and sort of aggregated and whatever, but unless you have an understanding of the risk profile of your population, it's really difficult to make clever decisions about how you allocate funding. And if we do want to move towards a more sort of sustainable NHS, then they need that data to understand how to allocate funding.
Yeah. We're obviously at an open-air conference, and people here will be passionate about structured, standardized data, and the importance of using standards when we're building digital healthcare solutions. Do you have any perspective on the different standards that are out there, or was that part of your thinking, or do you think that's maybe part of a future publication, or part of kind of the future of future thinking from your perspective?
No, it's obviously incredibly important. So the first paper I said was not a technical paper, it was more of a political paper. It was trying to win the argument about why we should have one. And I feel like we have made that argument now, because the government have come out and said that they want to have what they call a patient passport. And also in the paper we sort of set out these different options. I deliberately didn't come down one way or the other. I sort of set out and I said, look, we spoke to some clever people. They seem to think there's more than one way to skin a cat. You can do it different ways. But now I think we probably, with the next iteration of that paper, we would like to go into more detail and start describing at a more granular level what we think that should look like in the UK. And I think we will get into standards and that sort of level of detail. Yeah.
And I suppose another thing that you might want to, I'm sure you'll start to think about is, well, gosh, what's the right place to start in terms of what information do we start putting into a digital health record? And we've heard different things over the course of the conference, and people have talked about, for example, the International Patient Summary, the IPS, as maybe a place to start, or perhaps more information about an individual themselves that they want to record, and that's important to them, an about me type concept. Do you have any ideas of where might be a good place to start at all?
Yeah, I think it's important to think initially, what is it that you want the digital health record to achieve in the short term? Because it has huge potential, but it'd be very difficult to build something comprehensive overnight. And I think it would be a shame to say that it had to be perfect before you launched it. We've talked about that before. So I think having a version 1.0, 2.0, 3.0 is a really good idea. Yeah. Then I think it's really important to think about, it's what I was saying before about what's the technical design and what sort of functionality does that give you, because, and so what should we be including, in the first instance, to deliver some benefit. And I think that the first benefit should benefit the patient. So I think enough information for them to be able to have more autonomy over their own care. So I think enough information to start navigating digital pathways of care, I think. So being able to share their record with trusted third parties, to be able to access those models of care that I talked about, like remote consultations or have community care. And I think that's all sort of achievable within this sort of 5-term of Parliament.
And I love what you said there about giving the patients a sense of empowerment, a sense of control. And I wonder whether that ties in to one of the other strategic directions that the government has set out in the UK around prevention and around people talk about the left shift. Because we've known for obviously a long time that prevention is, we don't need a doctor to tell you prevention's better than cure. However, investing in prevention is a challenge. And do you think there is a case to be made, or can you think of examples of how a digital health record might be able to drive that prevention agenda?
Yeah, completely. The prevention argument is an argument that we've been having for a long time. And to be honest, we did a piece of work on that recently, and we commissioned somebody called Professor Andrew Scott to look at this issue and to do some macroeconomic analysis, because part of the reason I think we've sort of failed in our arguments about prevention is that whenever the NHS goes to Treasury and asks for more money, they say that health is wealth and they need to invest in it. And the Treasury just frankly aren't buying it. They're like, every time we give money to the NHS, it just goes into a black hole. And the arguments that we tend to sort of put forward are health economics arguments. That they're like, oh, you should give us money for prevention because it will reduce the NHS budget by X. And we know that's just total, it's just never going to happen. So what we didn't flip the argument, but changed the argument and said, okay, actually, if you spend, what we were saying was that not all health spending is equal, essentially, and that actually prevention spending has a better ROI than other types of spending, and that if you can ring-fence that spending and protect prevention spending, then actually this is the benefit that you will see not to the budget of the NHS, which will probably remain unchanged, but to GDP. This is how the impact of keeping people healthy and in work for longer. And we showed if you were managed to reduce the 6 long-term conditions incidence by 20%, what would happen to GDP within 5 years? It would go up by 0.75% within 5 years and about 1% within 10 years. And what was so important about that research is that it showed you didn't have to wait a generation to see the benefits, because that's quite often the argument is like, we say, we should invest in prevention, you'll thank yourself in 20 years, who's interested in that, especially not in government. So that's compelling, especially for the government at the moment that are thinking about how many people are off work and economically inactive. But the way that I think a digital health record feeds into that is that I think it allows you to deliver prevention in a very different way. And I feel like I can say this because I was a GP, but I'm not sure GPs do prevent well. I think there's a scope for us to do prevention much better than we are doing at the moment. And I think it could, take the example of the GLP-1s, for example, which is a really big hot topic. So huge potential to support the management of obesity. There are 4 million people in this country who are potentially eligible for GLP-1. I'm not saying they should all be on it, but they're all potentially eligible. We've got 35,000 weight management spaces, because currently you can only get it through weight management spaces. NICE looked at this and said, actually, we should be delivering this in primary care. And we should be delivering it for people with a BMI of 35 or over, plus some comorbidities. And usually when NICE says something, that edict is enacted within 90 days. Well, NHS England came back and says, oh, will you give us 9 years? And also, can we raise the BMI to 40? And the reason they gave, part of it is, I'm sure, is money, but the reason they actually gave is that GPs are too busy. And you don't need GPs to start delivering some of this stuff and to start delivering prevention. We could be doing, so Pharmacy First has been very successful, and there's huge potential to roll that out. But getting back to the digital health record, that could really support that model of meeting people where they are, which is not in a GP surgery. It's delivering care online, at home, and in the high street. And if you want to give pharmacies the opportunity to help people with weight management or diabetes management or long-term care, you need a central care record. You can't have a service over here thinking they're managing someone's diabetes and a GP over here thinking they're managing somebody's diabetes. And so you need a shared care record to sit on that. So that's what I mean about this record enabling you to deliver new models of care. The other way that I think it can support prevention, sorry, I know I'm really going
No, not at all. This is an important topic.
Is that, and I'm going to mention AI now because I work for TBI and we've got to mention AI.
I think everybody has to mention
you have
AI,
to mention
don't worry.
AI. But one of the things that AI allows you to do, one of the things that it's good at, is predicting. And if you can predict events, then you can prevent them. So I think there is scope, maybe not now, but in the future, once you have that kind of, because there is a kind of lot, when you mention AI in the NHS, you get a lot of crossed arms and raised eyebrows, and oh yeah, that's like in 10 years or something. But if we don't get our data sorted, you'll never realise the benefits of AI, and also you'll get crap AI because you've got crap data. So having all this health information in one place enables you to understand the full risk profile of one person. And I think that's important because right now, lots of people are seeking care outside of the NHS. They seek mental health support outside the NHS. They get their physio outside the NHS. They get lots of things outside the NHS. They need somewhere to help store that all in one place. Increasingly, if we do start rolling out making pharmacy first wider, then they're going to, there's going to be more instances of them getting their blood pressure measured in Boots, their hip done in a Spire hospital, their visitor. So you need somewhere to keep that all together. But once if you apply AI to that full picture, you can start to predict events, and if you can predict them, you can prevent them. And so what we're saying is, if you take that risk, you can communicate it back to 3 people that can do something about it. You can communicate it back to the patient through the patient portal to manage their own health better. You can communicate it back to the GP, you can then do proper panel management of their population. And you can communicate it back to the system, the insurer, the NHS. You can make better decisions about how to allocate funding, particularly how to allocate it to prioritise prevention spending, which so often lacks.
Yeah, I love that. I also loved how you talked about thinking about the workforce and about one of the concepts that we've been discussing a lot more recently is about trying to get people to work at the top of their competencies. And often we see services being delivered by people who may not necessarily be the appropriate people to be delivering that service. It might not be an appropriate use of resources. So I love how you've incorporated that. Okay, so we're coming to time. So I'd love to end by asking you how we can help. We're a room full of clinicians, technologists, people that work in industry who are very, very passionate about all the things that I think you've talked about. And certainly we're a group of people that understand the value of having high quality structured data to realize the benefits for health at a population scale. What can we do to help?
Well, I've already had help from quite a few people in this room. It's such an amazing community, and I think that, continue to, obviously doing what you're doing, but we're really trying to push this. Like, I really, really want to make this happen. And so, if you agree with our papers, share them. But if you think we're doing something wrong, please let me know, and please because I want to get to the right answer. I don't just want to get to my answer. So reaching out, I've really valued people that have done that and have supported, the work that we're doing. So that would be my ask. If you have anything you feel that you could be adding to if you don't agree with something I've said, tell me. That's my ask.
Amazing, and we've got very international community as well, and even in the room we've got people from lots of different countries. So as you've already highlighted, learning from different geographies is something that you're very open to do.
Yeah,
so
absolutely. That's
very exciting. Well, thank you so much, Charlotte, for joining us this morning. Can we all have a big round of applause for Charlotte? Thank you so much.
Thank you.
Don't leave just yet, because we still have a few minutes for questions. So do we have any questions for Charlotte?
Thank you. It's Brian from Better. I speak to a lot of ICS and ICBs who kind of instinctively understand this. The answer to the question when they talk to NHS England is the Federated Data Platform. And, okay, so where that might fit in, where it doesn't fit in, is it a spectre or... Because that's the answer to the question without even understanding the question.
We looked at that option in our paper. I think the FDP, has the potential to do a lot of things, but at the moment it doesn't have any primary care data. It wasn't set up or designed to be a digital health record. It was designed to support operational functionality, and I think it has potential to do that well. But I don't think it's designed to be a digital health record. And actually, to put to bet on that, I think, would be quite difficult because it's already struggling to make traction and to gain traction. It's seen as incredibly top down, and lots of people have had their arms twisted to sign bits of So if our aim is to get something done, then I probably wouldn't go down that road.
Okay, we had a few more questions.
Chris from Bupa, an insurer. Who owns the data in the electronic health record? Have you seen, does that vary? Who has control over the data in it?
I think, so one of the things that we advocated for is, I think the patient owns their data, but I think that we advocated for shared data controllership between the GP and the Secretary of State, because at the moment that's a real issue with getting data out of primary care. And I understand why they are worried about sharing that data, because they have liability. But yeah, that's what we advocated for, shared data controllership.
Hi, John Reddiff from Digital Health and Care Wales. Why is it not a digital care record? Why is it digital health, knowing the disparity between what we're doing out in the community versus primary and secondary care?
I think that it could become a digital care record, and maybe it's a really good point. It probably should be the digital care record right from the word go. That's probably an oversight. In my mind's eye, and probably in yours too, it would incorporate both health and care, so you can start to deliver, especially for those complex patients that are getting input from a variety of places. Yeah, it's a good call.
Hi, it's Canthan, orthopaedic surgeon, Birmingham. It's a great report that you've done, and also I think we could learn from other reports sort of done in the past. Particularly, there's something called the Co-Produced Health Record by the Aperta Foundation, and some really sort of important sort of work in that we probably could use. There's also the David Ingram's book, which is quite extensive, but I think that's a really good place to start to say, actually, why has things failed in the past? Because obviously a lot of the conversation around this sort of health record has been going on for 20, 30 years. So we had MP Fit and we had various other things. So clearly we don't want to then repeat the mistakes of those, right? So we need to have some sort of corporate memory, don't we? And need to be able to learn, because I'm fed up of it. And I want something that works for my clinical practice. I'm a full-time consultant orthopaedic surgeon, and I struggle. My wife's a full-time GP and GP partner, and she struggles more than I do. So there are lots of things that we can do, particularly around the open-air community and what we're doing as a group to really change this. Because doing the same thing over and over again is not going to give you a different answer. So we've got to try something new, or I'd say new. Open air's around 20 years. So, that's my ask as a practicing clinician who's really got into this because of the day-to-day issues that we have that you've described in your report. But I think we can add to that.
What do you think that new thing is?
So we talked about the Federated Data Platform, which I don't think is going to solve anything apart from operational data, number of patients in a bed, or length of stay. That's great for that. You can't federate siloed data. You know, how can you federate, you know, Cerner's and Epics across the country? They're in different formats. How can you learn from those? You know, you can't do anything. You have to curate that data. Who's going to curate it? You need a whole army of clinicians and experts in this to try and, you know, wrangle the data to then go actually make sense of it and then analyze it. It's not possible. You can't do that. So how do we build alongside it? How can we build this structured data, open-air modeling, alongside with what we've got? But then over the coming years, we'll have that data to then do whatever we want to do with. You know, so it sits within the NHS. Okay, and if you look at the One London presentation, you know, ask the community, ask patients what they want. They want their record shared. It's not about information governance. That's not the issue here.
Yeah.
This is about, you know, siloed vendor lock-in that we need to break.
Well, thank you both. Let's give them another round of applause, please.